Good morning. My name is Dr. Cynthia Magro. I'm the Director of Dermatopathology for Weill Cornell Medicine. Our talk this morning is going to address the pathology and pathophysiology of photoaging of facial skin. So this is a graphical abstract of normal skin, and we have the top layer, which is referred to as the epidermis. Then we have the subjacent dermis, and finally the subcutaneous fat. Coursing through the dermis are various structures that we refer to as adnexal structures that would encompass the eccrine apparatus as well as the hair follicle. This is a H&E stained slide of normal skin. That's hematoxin eosin. And here we have the top layer, which is the epidermis. We can see very well-defined reedy pegs or reedy ridges with interposed suprapapillary plates. What lies beneath the epidermis is the dermis, where the very superficial dermis is referred to as the papillary dermis, and then much of the dermis, in fact, is the so-called reticular dermis. And within the reticular dermis, we have blood vessels, smooth muscle as it relates to hair follicles, nerves, and adnexal structures. The actual composition of the dermis, being in the context of collagen and elastic fibers as well as hyaluronic acid, is primarily due to the dermal fibroblasts. Those are a cell type that really define the source of mesenchyme within the dermis. That is to say, what actually produces the structural integrity of the dermis, namely collagen, elastic fibers, and hyaluronic acid. So a very key in the barrier function of the skin from the external environment and also from preventing the egress of anything inside your body is the top layer, which is referred to as the epidermis. Now, the epidermis does have various layers. The basal layer is what gives rise to the remainder of the epidermis. It differentiates into a spinous layer, where you can see these very distinct intercellular bridges between keratinocytes, which in turn becomes the granular cell layer. One of the cardinal hallmarks of the granular cell layer are these basophilic granules, which represent profilagrin, which is the precursor to filagrin, which is very key for the structural integrity of the top layer of the epidermis, which is the anucleated cornified layer, also referred to as the stratum corneum. So what do we mean by the aqueous barrier? So the aqueous barrier is very key in terms of preventing the egress of fluid from the body and also really preventing external stimuli and products from entering into the body. So the aqueous barrier is maintained by lipid-rich lamellar Odlin bodies. Now the Odlin bodies are produced by the granular cell layer, and what they are is they are rich in lipids, and they really fuse with the keratinocyte cell membrane. And the contents of the Odlin body, which is really one that contains a lot of lipid, is actually released into the intercellular spaces within the top layer of the epidermis, which really adds to the integrity of the aqueous barrier. Then we have to recognize that that cornified layer, which is that anucleated top layer, that's ultimately what the keratinocyte differentiates into, is this anucleated top layer. That has to constantly desquamate or shed, and a very key enzyme that leads to that desquamation is referred to as aryl sulfatase, which in fact is found within the Odlin body. And I'd like to mention that the epidermis is constantly being renewed in all of us, and the renewal time is about 4 to 5 weeks. So from the time that the basal layer starts to differentiate into a spinous layer to the point of the evolution into the stratum corneum is about 4 weeks. So we regenerate our epidermis in full every 35 to 40 days. So this is another graphical abstract of that critical top layer of the skin, the epidermis, and you can see the basal layer. The basal layer is adherent to the basal membrane zone. The basal layer, again, differentiates into the rest of the epidermis. It's rich in keratins 5 and 14, and it is considered, a stem cell. It's a stem cell, basically. The stratum spinosum, or the spinous layer, that has very striking intercellular junctions. It's rich in keratins 1 and 10, as well as involucrin. As I was mentioning, the granular cell layer, which has that profilagrin, that also will have the odlin bodies. It's the source of the odlin bodies that contain lipid that add to that aqueous barrier. And then the very top layer, which is anucleated, which of course desquamates, is referred to as the stratum corneum, and that will be rich in lipids and certain proteins like loricrin and filagrin. Again, filagrin is a protein that will aggregate the layers of the stratum corneum and keep it adherent. So within the epidermis, there is a very important cell, and that cell actually characteristically resides in the basal layer, and it is referred to as the melanocyte. And the melanocyte is a neural crest derivative cell whose main function is to produce melanin. Now, melanin is produced in melanosomes, which in turn are transmitted to keratinocytes via the engulfment by the keratinocyte of melanocyte dendrites. So the actual melanocytes that produce melanin pigment have the melanin pigment within dendrites that in turn are phagocytosed by the keratinocytes. And the keratinocyte acquires melanin pigment through that transfer from the melanin-containing dendrite of melanocyte origin. And the melanin that's transferred into the keratinocyte forms a cap around the nucleus. And that is really key because that melanin pigment absorbs ultraviolet light and therefore protects the cell from UVB, that's ultraviolet B-induced DNA damage. And of course, the melanin pigment not only protects the keratinocyte, but it also protects the melanocyte from UVB-induced mutagenesis, which is obviously key in terms of light or ultraviolet light-induced malignancies of the skin. And so here's another graphical abstract showing the UVB light originating from the sun and how that UV light certainly has the ability to clearly damage DNA and lead to dysfunction of keratinocytes, dysfunction of melanocytes, and potentially oncogenic transformation. But the melanin pigment, in fact, does protect the cell from that UVB-induced injury. And of course, if there was no melanin pigment, that cell would likely undergo oncogenic transformation. Hence, you have the development of ultraviolet light-induced skin cancer. So this is just an interesting collage of images of the epidermis. It's an older person, and we can see how the epidermis has a bit of, I would describe it as architectural disarray and dismaturation. That brown pigment is actually in keratinocytes, and it's forming a cap around the nucleus, and that brown pigment, being melanin pigment, is derived from the melanocyte. And anytime you have, a lot of light exposure, you're going to have activation of melanocytes and the transfer of melanin pigment into the keratinocyte. So you end up having this state of enhanced epidermal melanization, obviously, when you are exposed to sun. And so this is just another view of epidermis that has been damaged from the sun. The epidermis is somewhat attenuated. There's a lot of melanin pigment deposition. Part of it is in melanocytes, but much of the melanin pigment is actually within keratinocytes. Now, this is an immunohistochemical stain, and we use a technique, a diamine benzidine technique, to basically highlight the melanocytes using the diamine benzidine. chromogen, brown chromogen, and the melanocytes are highlighted in brown, and you can see not only the intact cell, but also the dendrites are highlighted by the melanase stain, and it is these melanin-containing dendrites that are phagocytosed by the keratinocyte to allow that melanin pigment to be dispersed into the keratinocyte. And in this particular high-powered view, the melanase preparation of the A103, which is an immunohistochemical stain to highlight melanocytes, highlights the melanocyte, but the actual keratinocyte, since it is not of melanocytic derivation, is not going to stain with that melanase preparation. Now, the melanocyte does provide that protective melanin pigment for adjacent keratinocytes. And when you have one melanocyte providing that melanin pigment for a few adjacent keratinocytes, we refer to that as the melanogenic unit. Melanin pigment can be, broadly categorized into the brown melanin pigment, referred to as eumelanin, which involves the L-dopa, dopaquinone, leukodopachrome pathway, versus the blonde melanin, which is referred to as pheomelanin, and that has a different synthesis pathway using cysteine, as opposed to the L-dopa dopaquinone pathway that will eventuate into the blonde pheomelanin, which is much less effective in being a protective melanin with respect to UVB exposure. In fact, one might even suggest that pheomelanin may in fact be associated with enhanced toxicity to the cell with sun exposure. So now we're going to move on to the dermis. So I basically gave you an overview of the epidermis in terms of what its function is. It's really the barrier, if you will, its structural components, and how it has its main cell types in terms of composition are the keratinocyte, but also the basal layer melanocyte, and how that melanocyte performs a very key function in terms of protecting us from ultraviolet light exposure and injury. So now we'll talk about the extracellular matrix of the dermis. So most of the dermis that is subjacent to the epidermis is composed of type 1 collagen, about 80% of the dermis. About 10% of the dermis is composed of type 3 collagen, or the so-called reticular fibers. The type 4 collagen is basically found in basement membrane zones, basement membrane zone of the epidermis, basement membrane zones of the microvasculature of the dermis. Now, the other component of the dermis, over and above the collagen, are elastic fibers. And the elastic fibers, I'm just going to turn off this heater, range in size from about 1 to 3 microns, in contrast to collagen, which is much thicker. It's up to 15 microns. Now, the elastic fibers are interesting in terms of the elastic fiber network within the dermis. So within the papillary dermis, there are distinct elastic fibers referred to as oxytolin and eulanin fibers. The oxytolin fibers are vertically oriented. They actually insert and are juxtaposed to the epidermis. In contradistinction, the eulanin fibers assume a parallel orientation, and they are horizontal, even though they're in the papillary dermis, they're horizontal with the reticular dermis. Now, the elastic fibers that we refer to as the oxytolin and eulanin fibers, which are found in the papillary dermis, are composed almost exclusively of microfibrils. And that is very important because microfibrils are very key for resilience, which is what we associate with youthful skin. And there's no question that with aging, those resilient microfibrils within the papillary dermis become quite diminished. The other component of the elastic fiber network, which is certainly evident in the reticulodermis is the amorphous elastin, which in fact comprises most of the elastic fibers. And that's the extensible part of the elastic fiber network. So again, in the papillary dermis, most of what we see are those microfibril enriched elastic fibers, key for resilience and skin tightness, as opposed to the remainder of the elastic tissue in the reticulodermis, which has a significant composition being in the context of elastin, which is that extensible aspect. Now, the question is, what is the cell of origin in the dermis that produces the type 1 collagen, the type 3 collagen, the microfibrils, and the elastin? Well, it's one cell type, and that is the fibroblast. And the fibroblast will produce the collagen, the elastic tissue, and another important mesenchymal component of the dermis is hyaluronic acid, and that too is produced by the dermal fibroblast. And what's particularly fascinating, at least I think it's fascinating, is that the dermal fibroblast that actually produces all of this matrix is ultimately derived, interestingly, from the bone marrow, actually. And the actual cell of origin is a circulating cell in the bloodstream that is of marrow origin, probably of monocyte lineage, and we refer to that precursor marrow monocyte cell that gives rise to the fibroblast as a fibrocyte. And the whole concept of circulating fibrocytes of marrow, and very specifically monocytic lineage or origin, was that whole concept really was developed in the early 1990s. And not surprisingly, these circulating fibrocytes as a progenitor cell will exhibit certain immunohistochemical staining properties that would be consistent with the monocytic origin, specifically in regards to showing common leukocyte common antigen positivity, as well as positivity for the monocyte-derived dendritic cell marker CD14. And of course, when you damage the skin through whatever mechanism, it could be trauma, it could be something intentional, like ablative therapy for skin rejuvenating purposes. In point of fact, the cells that migrate into the skin are really derived from the peripheral bloodstream, and they are these progenitor precursor cells, which in turn are of bone marrow origin. And this is another interesting graphical abstract in terms of how the collagen is produced, basically, and formed and distributed in the dermis. So the precursor of collagen is called procollagen. And the procollagen is what is secreted by the fibroblast. And that procollagen undergoes cleavage into collagen monomers or propeptides, which will then undergo cross-linkage to produce collagen fibrils, basically. And I think the idea that putting topical collagen on your skin could somehow promote collagen synthesis in the dermis is probably a pretty flawed concept, as a matter of fact. So as I was mentioning, as far as the elastic fiber network is concerned, again, you have the oxytolin and eulinin fibers, which are found in the papillary dermis, and they are very rich in microfibrils. In fact, they are basically composed of microfibrils, which is key for resilience, while the remainder of the elastic fibers of the dermis contain elastin, which is what leads to stretchability and extensibility of the skin, as opposed to microfibrils being those elastic fibers that impart resilience. And so this is an elastic tissue stain. It's kind of hard to see, but basically the elastic tissue is highlighted in black, and you can see this kind of branched structure that is perpendicular to the long axis of the epidermis. And those are your oxytolin fibers. So that elastic tissue stain highlights very specifically the oxytolin fibers. So this is a patient who is clearly older and has evidence of photoaging of the face. So what are you seeing here? These are not the same patient, but first of all, we're seeing wrinkles. That's pretty obvious. We're seeing blotchy erythema or redness. We are seeing this element of laxity to the skin, and very importantly is the irregularity in pigmentation. So the skin has blotchy erythema, irregular pigmentation, laxity, and wrinkles. So how do we explain what we're seeing here grossly, microscopically? Well, first of all, let's address the irregular pigmentation. With ultraviolet light exposure, you're going to get melanocyte activation, all right? So the melanocytes will become more active in terms of synthesizing melanin pigment, and they'll also increase in numbers. You get so the melanocytes are more activated, and there's melanocytic hyperplasia. And as a consequence, you will have an increase in epidermal melanization, where that melanin pigment is distributed in keratinocytes. So it is the combination of the melanocytic hyperplasia and the increase in melanin transfer into the keratinocytes that occurs as a photoadaptive phenomenon with light exposure, with ultraviolet light exposure, that leads to the irregular pigmentation. Now, what about the pathogenesis of wrinkles? Like, what actually accounts for the wrinkled, skin? It's a few things. Number one is the actual collagen network within the dermis is clearly reduced. So a very key component of the wrinkle is the loss of collagens, typically collagen 1. And the loss of the collagen is going to be primarily in that portion of the dermis that is closest to the surface, where it receives the maximum amount of light, sun exposure. And what happens is that with sun exposure, with ultraviolet light exposure, the fibroblasts that produce the collagen become dysfunctional. They're actually damaged. So they can't produce the collagen properly, quantitatively and qualitatively. In addition, a very key event happens with sun exposure, which is there's upregulation of enzymes that digest the collagen and elastic fiber matrix. And those enzymes are referred to as metalloproteinases, and they become very activated with ultraviolet exposure. In addition, there is the accumulation of this very abnormal tissue in the superficial dermis that we'll talk about soon, called solar elastosis. So the normal collagen is not produced as much, plus it's digested, and instead the dermis is replaced by this basophilic elastotic material referred to as solar elastosis. Another feature of the wrinkle, paradoxically, is the fact that the epidermis, instead of being undulated, as you might think if it was a wrinkle, it's actually flattened. So the epidermis undergoes this progressive resorption or attenuation, and so flattening of the epidermis is another factor that contributes pathogenetically to the wrinkle. As I was mentioning, the eulinin and oxytolin plexus in the papillodermis are really key for that youthful, resilient skin. And with ultraviolet light exposure, the metalloproteinases digest that oxytolin eulinin plexus, which contributes, of course, to the formation of the wrinkle. So this is actually a 75-year-old, the back of a 75-year-old, where the back of this gentleman really showed minimal aging. When you look at the back of a 75-year-old, it may be very difficult just on clinical examination to distinguish that back from the back of a 35-year-old. And that's very different than the significant aging that is evident in the face of a person who's 75 as opposed to somebody who's in their 30s. And so here we have this back skin that has not seen much sun. Note the epidermis has complete structural integrity with reedy ridges and interposed suprapapillary plates. You don't have that flattened epidermis that we see in the photoaged skin. This is the dermis, and all that pink material is collagen. It looks fine, it looks pretty normal. There is a stain that we use to highlight collagen, which again is that pink, these pink bundles, somewhat haphazardly disposed in the dermis, is a trichrome stain. It looks perfectly normal. The elastic tissue is highlighted by the elastic tissue stain, whereby the elastic tissue will be black, and as I was mentioning, the elastic tissue, the fibers are much thinner than the collagen fibers, and the overall collagen to elastic fiber ratio does favor collagen over elastic fibers, but the elastic fiber network here is well preserved, and very importantly, that elastic microfibril enriched ullinin and oxytolin plexus is completely preserved. So despite the patient's age, the skin looks actually very good, and that is because this person did not expose his back to the sun. In contrast, that same patient had skin biopsies from the face. Actually, it was for an invasive squamous cell carcinoma. This atypical endophytic squamous proliferation here is an invasive squamous cell carcinoma that developed due to sun exposure. First of all, the epidermis is quite abnormal. As opposed to this being totally normal, the epidermis ranges from being somewhat hyperplastic to areas of reedy ridge effacement. Also, the dermis, instead of having this normal appearance with bundles of pink collagen, the superficial dermis is replaced by these coalescing nodular foci of basophilic gray material that we refer to as solar elastosis, with only a minimum amount of residual collagen bundles. So this is severely damaged skin, damaged through light exposure, leading to the irradiated fibroblasts producing abnormal collagen, the dissolution of the normal collagen, etc. And again, we'll talk about what is this basophilic material that is solar elastosis. That is a very key component of the wrinkle. And this just shows you actually wrinkled skin, where the epidermis again is quite flat, and in the subjacent dermis, instead of having the normal collagen, those pink bundles of collagen, you have this basophilic material that we refer to as solar elastosis. And this is an elastic tissue stain which highlights the basophilic abnormal material, indicative that the solar elastosis in fact contains aggregates of abnormal elastic tissue. Also note that you're not seeing that nice branching network of ullinin and oxytolin fibers that we know are very key for structural integrity of the skin. So again, we'll address the pathogenesis of solar elastosis, which is an integral component of photoaging and facial wrinkles. So what are the different ultraviolet wavelength components? We have UVA, which is between 320 and 400 nanometers, UVB, which is between 280 and 320 nanometers, and then the germicidal UVC, which is between 200 and 280 nanometers, and they have all distinct mutagenic properties. But the hallmark of the germicidal UVC and UVB mutagenesis is the high frequency of transition mutations at dipyrimidine sequences containing cytosine. In human skin cancers, about 35% of all mutations in the p53 gene are transitions at dipyrimidines within the sequences of 5-TCG and 5-CCG, and these are localized at several mutational hotspots. And the P53 mutation, which is through UVB mutagenesis, affects keratinocytes, melanocytes, and fibroblasts. Keratinocytes, which of course are the source of, really the structural integrity of the epidermis, the melanocyte, which is the source of melanin pigment, and the fibroblast, which of course is the source of collagen, elastic tissue, and hyaluronic acid. So here again is the contrast of the back of the 75-year-old. This is a trichrome stain. Everything looks perfectly normal. Note the epidermis as preserved architecture, abundant collagen. In contrast, the trichrome stain on the face of the 75-year-old, much of the superficial dermis is not highlighted by the trichrome stain because it's being replaced by this abnormal material called solar elastosis. And so, what is the pathogenesis of solar elastosis? Is it synthesis of abnormal tissue by these irradiated fibroblasts, or is it degradation of pre-existing connective tissue matrix, or is it potentially a combination of the two? So it would appear that it's likely a combination of the two. So we do have clearly evidence of degradation of pre-existing matrix components, specifically collagen and elastic fibers, but we also have evidence to indicate that there is a de novo synthesis by irradiated damaged fibroblasts of unhealthy elastic tissue composed primarily of stretchable elastin with a minimal microfibril element. And another feature of solar elastosis is glycosaminoglycans, probably hyaluronic acid. So that basophilic material then in the superficial dermis, which is so integral to aged looking skin, is a combination of the degraded collagen and elastic fibers, the synthesis of new but abnormal tissue, especially elastin, which is that stretchable kind of elastic tissue, and some hyaluronic acid, which probably contributes to the basophilia microscopically. Now, very key to all of this, these abnormalities, is the activation of these enzymes that digest the collagen and elastic tissue. And there are collagen-lytic metalloproteinases found in the skin, including MMP1, MMP8, and MMP13. And these metalloproteinases are activated with light exposure and will digest the collagen and elastic fiber network. So again, we have the enhanced expression of these metalloproteinases upregulated by UV exposure. These metalloproteinases have collagen-lytic and elastolytic properties, leading to progressive attenuation of the connective tissue matrix of the skin. And the end gross morphologic sequelae is lax and wrinkled skin, basically. So now we have to address, and this is the end of my talk, is therapies. What are the therapies that might, ameliorate photoaging, basically? Well, obviously, what we have learned is that aged-looking skin would not happen if there was no light exposure, ultraviolet light exposure. So very key in really prevention is sunblock, is to use a very effective sunblock, number one. Number two is we know that the aqueous barrier in the epidermis is impaired with aging. That is to say, the stratum corneum is not as structurally intact. So you can replenish the integrity of the stratum corneum with certain topical agents. And I have always loved using botanicals like rose absolute, their red and black Korean ginseng, various rice extracts like rice bioferment, rice hydrosylate, rice water, rice starch. All of these natural botanical components can actually restore the integrity of the stratum corneum. Well, you saw how with photoaging we get irregular pigmentation in the skin because of the melanocyte hyperplasia induced by light exposure. Well, there are certain topical agents you can do to reduce melanocyte activity, to actually reduce the synthesis of melanin pigment and downregulate melanocyte function, such as niacinamide, white peony extract, and rice extracts. Another feature of the aged skin is this epidermis that is just not proliferating properly, and in fact can show either hyperplasia or significant atrophy. So there are certain topical agents like rose absolute and ginseng that can promote keratinocyte differentiation. Well, what about restoring the elastic fibers and collagen by downregulating metalloproteinases? There are a variety of topical products: retinoic acid, viola tricolor, white peony, boswellia, turmeric, red ginseng, sea buckthorn. All of these can potentially reduce the metalloproteinase activity, which is key for the digestion of the collagen and elastic fiber network. And you can replace that elastotic dermis with new healthy fibroblasts that will synthesize normal collagen and elastic tissue. And so one way is laser resurfacing, radiofrequency microneedling, but you can also still use topical botanicals like viola tricolor, white peony, boswellia, red ginseng, niacinamide to help promote collagen and elastic fiber production by fibroblasts. Many years ago, I was involved in one of the first studies on the utility of CO2 and erbium lasers and resurfacing for facial wrinkles. I had the great honor of working with some outstanding people back in my Boston days. It was spearheaded by Rox Anderson, who is really considered the father of modern day cosmetic lasers, and I had the opportunity of working with Khalil Khatri and Victor Ross and Will Greveling. And basically we were looking at these two different types of lasers, the erbium and the CO2 lasers, and how they were effective in improving wrinkles, the erbium not having quite the same thermal damage as the CO2 laser. But again, I'm not going to go into detail about that. I just want to show you how you can actually replenish the epidermis and replenish the superficial dermis through laser resurfacing, basically. Now, of course, it's not a painless procedure, and you do have downtime. So this is a patient who had the resurfacing. On the right side is the CO2. Again, that's more thermal injury, as opposed to the left side that was treated with erbium. Now, I did the histologic studies, so when you actually do the ablative therapy, whether it's the erbium or the CO2, you're ablating the top layer of the epidermis, so it's gone. You also are inducing thermal injury. It's relatively superficial into the superficial dermis. And part of the study was to actually measure the depth of thermal injury. And then several months later, we re-examined the skin, and it was completely reconstituted. So the epidermis appeared normal, and the elastosis was gone and replaced by normal appearing collagen and elastic fibers. So there's no question that resurfacing the skin with such techniques can be quite effective in dealing with photoaging. These are just various articles that are of interest to me, and there are many articles. These are just examples of articles that deal with botanicals and their role as an anti-aging or at least improving the look of photoaged skin. Like the papers on red ginseng extract and how it has an ameliorative effect on UVB irradiation, boswellic extract or boswellic acid rather, the whitening effects of certain plants like sea buckthorn, etc. So that's it. I hope that you found this talk interesting in terms of understanding the basic anatomy, microanatomy of the skin, what happens with photoaging, and how there are certain things that we can do to improve the appearance of photoaging, and certain things that we can also do prophylactically to prevent photoaging. And as you know, all of these slides are available for people to download and use for their own purposes, whether it's to give a lecture or just study this interesting and fascinating topic. Thank you.